Hi, my name's Andrew McNamara. I'm a board-certified orthopedic surgeon. I've done a fellowship in upper extremity surgery from elbow to the hand and wrist. And I work at the Orthopedic and Fracture Clinic here in Mankato, Minnesota. I did my fellowship at a program where they pioneered a system that allows us to use computer navigation when doing the shoulder replacement, and that allows us to be very precise, accurate in placement of the implants, and ultimately gives us the best outcome for the patient. And one of the most rewarding things for me is to see the patient between 3 and 4 months after surgery when they're starting to get back to the activities that they love doing. So this is the planning software, and as you can see, we have a 3D model of the scapula, the shoulder blade. This is one of the front bones, the coracoid, and the acromion is over the roof of the shoulder. And you can see we have the implant, so we can remove the glenosphere. Here's the base plate, and this software allows me to place the base plate very precisely in 3D space. We can choose between different types of implants and sizes of implants. We can go to this view and scroll through where we can see exactly how much bone is going to be surrounding the implant on two different planes. We can see the bone spurs across the humerus and the bone stock on the glenoid side. And then we can also use this tool to remove the bone spurs on the face of the glenoid. You can see in two planes where those bone spurs would be removed. Once we're done with the glenoid side, we can move to the humerus. And here you can see where the stem would be placed. We can size the stem anywhere, so from 6 millimeters up to 14 millimeters. That would be quite large. And then there are various views here where we can see in two different planes where the stem would be placed. We can also alter the angle that we cut the humerus. So we call that retroversion. And here you can see in real time how that's changing. Once we've decided on that, then we can move to a picture of the entire joint. And the real power of this software is that it's able to predict for us what the final motion is based on where we have placed the implants and where the bone spurs are. A lot of times the bone spurs will prevent rotation of the joint, and so we can plan where to remove those. Here you can see abduction, moving the arm outward, forward elevation, moving the arm upward, and then rotation in this plane, and we can see what those degrees are. So quite a powerful tool that has really expanded our options for the patient and helped us provide better outcomes. We're prepped and draped. We're going to make an incision from the coracoid process, which is the one of the bones that sticks out at the front of the shoulder here, down to about the mid portion of the humerus. So we'll start by making a skin incision, about like that. And then we're going to use a coagulation tool called the Aquamanus to get the skin bleeders. Okay, then we're going to make our way a little bit deeper through this subcutaneous tissue. So some skin bleeders, we're just going to kind of get some hemostasis here in the subcutaneous tissues. This instrument I'm holding is a bipolar cautery, meaning the current goes between two little terminals at the end, and it just coagulates in between the tip of the instrument. And it's very effective at coagulating these small blood vessels. And as I'm going, I'm just dabbing the tissue, not wiping it, so that I don't wipe away the clot that we've established. Okay, so right here is going to be the cephalic vein. You can see that coursing up here. Not a ton of fat around this one, but you do see a little bit of fat tissue right here. All of this muscle here is the deltoid, which I'll show you in a while. We're going to take measures to really protect that muscle. And so now the next order of business is to look at the perforating vessels, the little connecting vessels that go to the vein. I prefer to mobilize the vein medially, meaning inward, and that just keeps it out of the way, keeps it protected. Let's take an Army-Navy. So we're going to start up top here where we've identified the vein, and we're going to pull it inward medially, and we're going to look for all these little connecting veins. So here's one. Small little vein. And we're going to cauterize that. Excellent. Now what we're going to do is take off some of the tension on the deltoid. And then I'll take a Cobb elevator. This is just an instrument that frees up tissue adhesions, meaning scar tissue. So what we're going to do is come underneath the deltoid into what's called the subdeltoid space. And we're going to create some space. In people who have had rotator cuff repairs, there will be scar tissue in here that we want to free up. This patient hasn't had a rotator cuff repair before. So it's relatively easy. Okay, well, and then we're going to protect our deltoid. Go ahead, Brent. We'll take the brown deltoid retractor. There we go. So now this is a retractor that goes underneath the deltoid and fits onto the humeral head. So we're going to slide that underneath here. There we go. Just like that. Kind of push down on that. Okay, and then we'll take our Army-Navy again. And then, good. Okay, so now what you're seeing is, let me see, yeah. So this is, underneath here is the humeral head. This is what we call the conjoint tendon, which is running up to our coracoid. And then the biceps tendon runs in a groove right out here. And this fascia on top of this is called the clavipectoral fascia. What we're going to do next is come underneath our conjoint tendon and look for some little vessels. These are called the anterior circumflex humeral vessels, also known as the three sisters. And these are vessels that will bleed if you don't control them. So we're going to do that right now. Okay. And then this would be the time to inspect the rotator cuff to see if we do a conventional anatomic shoulder arthroplasty or a reverse. And this patient's glenoid is very worn towards the backside. We call that a retroverted glenoid. And so we're going to plan on doing the reverse. This is going to be the biceps tendon sheath. So we're going to take the cautery and we're going to come into this groove right here. And this fluid is joint fluid that's in the tendon sheath. And so we're going to come down here. The pectoralis muscle, the chest wall muscle, comes underneath the biceps and inserts on the humerus. Let's come down here. So we'll take the fiber wire. And what we're going to do next here is what's called a tenodesis, meaning we're going to fix the biceps tendon to the pectoralis muscle. So we're going to take this suture, pass it through the biceps, pass it through the pec muscle, which is this muscle underneath here. Take some nice big bites to secure it. And then we'll tie this suture. And I like to do 2 sutures for this. Scissors. You could consider letting the biceps retract down, but that can give the patient some cramping and an uncomfortable appearance to the upper arm, so I prefer to do the tenodesis. Now what we're going to do is cut the biceps just superior, just up from where we tied it down to the pectoralis, and then what you can see I'm doing here is just lifting the biceps tendon out of the groove, and we're going to get rid of that. And then we'll come up in here between the top rotator cuff tendon, the supraspinatus, and the front rotator cuff tendon, the subscapularis, and we're just going to develop a little interval. And then sometimes there's some branches of those 3 sisters, the anterior circumflex humeral arteries, in this groove. So we're going to coagulate those before they become a problem. Okay, so again, you have conjoint tendon here. This is going to be the subscapularis, which is the front rotator cuff muscle. And so what I'm going to do now is just take my cautery and I'm going to peel it off of the bone. This part of the humerus is called the lesser tuberosity. It's basically a protuberance of the humerus where the muscle inserts. And so we're going to peel that back to gain access to the shoulder. Let me see that tag stitch. I'm going to put this stitch into the muscle to help get control of it. Then I'll take the snap. Okay. And then let me take a single Holman. Okay, we're going to put this retractor in there to give some tension on the rotator cuff. And I'm going to externally rotate the arm. And that's going to put some tension on these remaining fibers of the subscapularis, the front rotator cuff muscle. And what this fluid you're seeing is joint fluid. And so we're just going to evacuate that as we go. And I'm just using the cautery to gently peel this back. We're going to release a little bit of the capsule going inferiorly. Like that. We know from our preoperative templating that this patient has large bone spurs, large osteophytes. And so we're going to have to work around those and eventually remove those. Okay, so now that that's more or less complete, what we're going to do is dislocate the humerus. And so I'm going to put a retractor behind the head right there, and then a fork tip, yep. We're going to put that here, and then we'll take another one of those. Okay, so we're going to dislocate by just dropping the arm like this and putting some gentle pressure on the soft tissues. What that's going to do then is expose our cartilage, or what's left of it in this case. We may need to do a little more releases here just to free things up a little better. Again, this inferior capsule, the underside of the joint is going to be a little contracted. So we're going to free that up some more. And here you can see the very worn cartilage of his humeral head. Can we get another one of those? So now we're in a place where we can make our humeral head cut. And again, because of our templating, I know the angle that I'd like to cut it at. And so we have a guide that we use for that. And I'm going to position our arm sort of like this. Okay, and so this guide will help me achieve about a 25-degree angle. Here's 30 degrees, here's 20. We want to be somewhere in between, somewhere about like that. Okay, and then this is just an oscillating saw that we use to cut the humeral head. So we're going to do that now. Okay, so that gives us that cut, and then I'll take a osteotome. We're just going to run this osteotome back and complete the cut. Okay, and that was a pretty clean cut. You can see here, this is what we call an eburnated bone, meaning polished. All of the cartilage is basically worn down. And then you can see some of the bone spurs coming off the edge. So that was a good cut. Okay. And then we're going to come in here and clean this up a little bit. We can see our biceps a little better. Can I see a pickup? And we're going to come under here and just remove what's left of the biceps. Okay, and then let's go with a medium head protector. So right now I'm feeling the bone of the humerus, and I can see that it's pretty robust. You know, he's got really pretty good bone quality. We could also feel some of these bone spurs on the underside. So let me take a rongeur, and I'm just going to come underneath here and remove some of those spurs just to get them out of the way. It also helps improve our visualization to have those gone. That's bone spur there. Now we're going to put a head protector on the humerus. It's basically this little pizza pan device. It's got looks like a pizza pan. And we're going to put that over the head just to protect it temporarily. Slide it under there. Okay, and then we're going to bring the arm back out. Now we're going to go to our glenoid. So keep that in there. I'll take that. And then we're going to reposition our retractors. And this is an osteotome or a chisel, and we're going to come right along the front side of the socket, the glenoid, and we're going to slide this down the front of the socket. And that's going to allow a little space for this retractor called the Job humeral head retractor, and it's going to slide in there. And then I'll see the Carmel clamp, and then we clamp this to the drapes. And that allows that to sit like that. Oops. Now, what we're going to do at this stage, we'll take a Ferris rongeur. We're going to go in here and look at the labrum, which is the lining of the joint. And I'm just going to improve our visualization here for a second. Okay, so this tissue right here is the degenerated labrum. So that needs to be removed. I'm just going to take the cautery and come around this. Sort of like peeling an orange rind. You know, it's like the Italian waiters. You just peel it off. And that cleans that up pretty well. There we go. Okay, go ahead and suck in there. Okay, and then we'll take the wolf retractor. Retractor that's designed to go behind the glenoid, and it just helps give a little extra leverage to improve our view of things. So we're going to put this in towards the back here. You can see the socket a little better. Yeah, let's go ahead and wash that off. Excellent. Okay, let me see a Cobb elevator. We can see there's not very much cartilage left on this glenoid, on this socket. And so I'm going to just scrape what's left of it to get that off. There's really not much at all. And we can also see how worn the socket is towards the back. We call that retroversion. And we knew from our templating that that's about 15 degrees, which is a fairly good amount of wear. So now what we're going to do is create a little space up here on the coracoid. And I'm going to clear the soft tissue along the neck of the coracoid. And then to release a little bit of the pec minor insertion on the coracoid to clear that off. Okay, so this bone right here is coracoid sticking out at us. We're going to take this camera arm, and this is going to be for the GPS sensor, which is guided personalized surgery. There's no satellites involved. But this little arm is going to temporarily go onto the coracoid, and we're going to fix it with a pin and a couple of screws. So we're going to drill the hole with the pin, and then put the short screw in. And then we're going to drill another hole. Again, this is just temporary. This allows the computer to have a fixed point on the shoulder blade. So that we can use the computer navigation. Okay, and then we'll take that back. Good. Okay, and then this is a little tracker with 4 little infrared sensors. And that's going to go onto this arm. And then we're going to position this computer over here so that it can read the sensor. And then we'll take this probe, which has 4 more infrared sensors. And now what we're going to do is touch several points on the shoulder blade, socket, coracoid, in order to interface with the computer. And this will match with the CT data that we got preoperatively. We'll come up front first. On the front part of the coracoid, we're going to just trace this line. And then the back part of the coracoid. There we go. And then the neck of the coracoid. And we're just painting this area. We just have to have the probe somewhere in the vicinity of where it shows on the screen. Now we're going to the socket, and we're going to touch top, bottom, front, back parts of the socket, as well as the surface of the socket. And then we're going to come along the neck, along the bottom of this. And then this is the front edge of the socket. 2 points there. And then the back edge. The reason we can do that easily is we have that wolf retractor back there to show it to us. Okay, and now we're looking for green or yellow dots here. That just indicates that where we've touched matches the CT data. And that means that we've gotten good acquisitions. Yeah, excellent. There's one little red spot. But what I'll do next is test it with this probe to see if everything makes sense. If it does, we'll proceed. So I'm going to touch the socket, and if it says 0, yeah, okay, so it's saying 0, so that's reading accurately. And same thing on the neck of the coracoid there. So I think we're good to proceed. All right. Next, we're going to drill a pilot hole. This is just a little reamer, or a little drill with a sharp point that's going to go into the center part of the socket. There you go, right like that. Okay, and then I'm looking at the screen and I'm trying to find the exact center where this needs to be. This is going to basically function as the starting, or as the pilot hole for our reamer, which I'll explain in a minute. Okay, so that's a pretty good representation there. So we're going to drill that in. And then we're going to put our reamer on here, which is basically a rotating blade that'll plane the glenoid. It'll smooth it down to where we need it. And because we can navigate this, we can put it pretty precisely where it needs to go into our pilot hole. And then we can ream this down. All right, so once we get it started, we know from our planning that we're going to take off a fair amount of bone from the front because of how it's tilted towards the back. So I'm going to clean this up a little bit here. I'm going to put our reamer roughly down on there. There we go. Okay, so now now that we're closer to 0, we can dial this in a little better. And we're gonna follow this trajectory. Right. Like that. And then once we get to 0, we know that we've gone far enough. Now, because he has such a large glenoid, there's a little bit of a rim here of bone spurs that we're going to need to remove. So we'll do that next. Let me see the ferrous rongeur first. And again, we knew that based on our planning that we'd have a lot of bone spurs along the front side. The issue with those is that they can impinge, meaning they can prevent motion of the final construct at the end. So we do want to remove those if we can, both on the front and back sides. We can do this at this point because we've already gotten our acquisitions with the computer. If we did it ahead of time, it would interfere with that. All right, next we're going to be ready for our central hole. So we'll take the drill back. Okay, and then this is where it becomes really important because we're going to drill into the glenoid. And the way I like to describe this is it's sort of like drilling into the side of a dinner plate. There's really not a lot of bone. As you can see there, there's only one place for this implant to go. And the good thing with our navigation is we can be super accurate when we drill this. So we're going to follow this down. Okay. And there we can see that we're pretty much where we want to be. We're inferiorly inclined, a little bit of anteversion. That's where we planned it. Okay, so we'll go ahead and accept that. We're going to mark that position. Okay, and we're very, very much on target there with that. Good. You have the small posterior. Okay. So this is our base plate implant. So I don't know if you can see on the camera here, but it has an angle to it. So it's shallower in the front, deeper in the back. And then it has a cage here that we've filled with bone graft from the humeral head. And this is what our ball is going to be attached to. So we're going to implant this into our drill hole. And then we're going to gently mallet this in place. Let's get our G going there. There we go. Okay, so we're just going to mallet this in place. And once it's down, we're going to turn it so that our rotation is correct. We start about 16 degrees off, and right there looks perfect. Okay, so we're going to register that. Great. And that's the perfect spot for this. Okay. Now, in order to secure the base plate to the bone, we're going to drill some screws. And again, we're going to navigate this. So I always start with the inferior screw because that's one of the more important ones. That down. Good. Okay, and then what you can see on the screen, in two planes, we're able to see where this drill bit is going. And it should also tell us the depth as we drill. So we're going to start the drill. So there's an 18 millimeter screw. We're going to keep going. We're going to aim for that deepest part of the vault. And we're going to say that's a 38 millimeter screw. So we're going to take a green screw. And then, yep, enter. And then we're going to come to the bottom front screw hole. Enter inferior screw. And again, we're going to aim for that deepest part of the vault. Okay, we'll go red with that one. 34 millimeter screws, pretty good. And then we're going to come again this way into the vault on the back side. Okay, we're going to go red there too. Okay. Green. Okay, so then we're going to place this screw with a drill. We're going to be careful how fast we put it in, because we don't want to strip the screw or do anything crazy. So we're just going to let that go down nicely. And then we'll take our second screw. Let the screw fall through the hole there. Good. And then the third screw. Along the back. Okay, and we'll have the hand. So then I'm going to tighten the screws on hand because I have more control over it that way. And I want to be able to feel the resistance of the bone as I put this in. And that really feels excellent on the inferior, the bottom screw. Front is excellent purchase. And then the back is also quite good. So 3 screws is enough. Then what we'll do is we put these little caps. These are called locking caps. And they thread into the base plate. And they make it so that the screws are rigidly fixed to the base plate. At first we compress the screw, which compresses the base plate to the bone, and then we lock it in place with these locking caps. So it's really a very elegant design. Okay, so now all of that is nicely locked in place. We're going to clean things up here a little bit. Great. And then this is called the glenosphere. This is the ball that's going to go onto the base plate on the shoulder blade. Let me see a Ferris. Little piece of bone we're going to get out of the way there. Okay. And then this is going to slide into the base plate. Okay, and we're going to tighten that down. I usually give it a couple more taps just to be sure that we've got it. Good. Okay, now let's take this out. We're going to take our CUDA out. We'll take an Army Navy and we'll take off the camera arm. Okay, so now we're just taking off our temporary camera arm that we placed on the coracoid. We're going to take out our wolf retractor, and then we're going to put our brown deltoid retractor back in. And now we're going to move on to the humeral component. So we're going to re-dislocate the shoulder. You have the black shoehorn. The patient has a pretty substantial bone spur along the back of the humerus, so we're going to remove that next. That's part of what's limiting our exposure here. So now we're looking at our humeral head bone, and what we're going to do next is sink down a canal finding reamer. So this is going to come down the outside here, and we're going to find the center of the humeral canal with this. And then next we're going to place a broach. And this has our alignment guides on it. So we know we want about 25 degrees for this patient. So we're going to split the difference between these two rods and put this down. So that's a 6 millimeter. We're going to go up a little more. This is the 7 millimeter broach. You can see the broach has little serrations on it that are designed to remove bone to create space for the implant. Good. Okay, let's go up to an 8. I think an 8 will just about do it. What I'm looking for here is how stable the implant is in the bone. These are designed to get fixation in the top part of the humerus. And you can see as I'm twisting that, that's turning the whole humerus. So for me, that's enough. We don't need to get too aggressive and put in a large implant. Okay, so then what we're going to do is plane the bone. We'll take the small planer, Dalton. So we're going to remove a little more of this bone with this planer. And then we'll trial off of a 700. Okay, so we're just going to sink that down like that. We're going to have anesthesia team totally relax the patient's muscles, because what we're going to do next is put the shoulder back into position or reduce the shoulder. And this has a trial on the humeral side, so we're going to see how tight this is. Okay, and that went in fairly well. What I'm going to do now is look at my implant. I'm going to pull on the arm and see how loose it is. And this is not loose at all. I'm going to put it through a little range of motion. So as I come into external rotation, that's quite a lot of external rotation, over 60 degrees. Right there, you can see it's lifting off just a little bit. But at 45 degrees, we're okay. 30 degrees, we're okay. So that's pretty acceptable. We can also take the arm out of this arm holder and look at our range of motion coming inward like this. Coracoid's okay. I want to make sure the coracoid's not getting pushed on by the humerus bone, and it's not. And then we can look at our forward elevation coming up this way, and that's really quite good. Okay, so we'll take that. We'll do 008. Sure. So next, what we'll do is we'll take a bone hook, and we're going to dislocate the shoulder again. Shoulder's dislocated again. And now we're going to take out the trials. You see a freer? So we'll take out this trial and then the stem inserter. All right, now we're going to wash the wound with betadine, peroxide, and Iricept, which is chlorhexidine. It's an antiseptic solution, just to prevent any possible infection. And then on the back table, we're going to assemble the implant. If you want to, yeah, sure. So this is our little assembly station. We have the stem here. This tray goes onto the stem like that. And then there's a little set screw that goes into it. We need to make sure that this is aligned perfectly. There it is. There we go. Okay, and then once that's reasonably tight, we'll take our torque tool and this will fit in here like this. Yep. And this will torque that screw, and it'll break off the top little head of the screw. You have your so this is the little head of the screw that gets broken off, and now that's torqued in there to the right specification. And then this plastic piece fits in there like so. You have the impactor? Yeah. And then we impact this into place. We check it to make sure it's down. Great. So this is our fully assembled implant. We're going to finish doing our washing in the shoulder, and then once everything is set, we'll be ready to implant the humerus. All right, we're going to get reset up here. We're going to re-expose the humerus. Put this lap sponge in. You know, again, through the whole case, we've been protecting our deltoid because the deltoid is the muscle that's going to do the work of moving the arm once everything is done. So we're going to put our retractors back in. We're going to re-expose things. Okay, we'll take a little bit. You have a little bit of graft. How much do you have left in there? Oh yeah, that's plenty. Okay, so then what I like to do is I'll take a little bit of graft from the head. Here's our humeral head, and we've taken some graft from it. And I like to just pack it into the top part of the humerus. Do you have a little pickup? Yeah. This patient has really pretty good bone quality, so we don't have to do a whole lot here. But this just gives a little extra reinforcement. Because we're not using cement, the fixation here is from the bone growing into and onto the implant. In my view, cement is like a grout. It can chip and crack and cause problems down the road. So I choose not to use it. And I think that's the larger trend nationally. So we're just setting the implant into the humerus. It's going to follow the path that we broached, and then we're going to mallet this in place. And you'll see that just kind of tracking down where it should go. We're going to get that nice and solid. Great. Okay, now we'll take an Army Navy, and then we'll take out our brown deltoid. Go ahead and keep that in place if you would. Great, that's good. Okay, and now what we're going to do is reduce our joint. So we're going to just put some firm pressure, and that clunks into position very nicely. Now you can see our final implant. Again, I'm pulling on the arm, and there's very little play in that. Our deltoid is helping to maintain the pressure to keep that reduced. And we're going to check our motion here. Again, quite nice, all the way out to over 60 degrees of external rotation. Go ahead and relax now on that. And then we're going to bring the arm up. And that's also quite nice. We're going to check our internal rotation. Yeah. Okay, good. So next step will be to put a little powdered, we'll wash out the wound. We'll put a little powdered antibiotic, vancomycin is what I use. We're going to put that into the joint. Just to be on the safe side. So it's just a little white powder. We sprinkle that into the joint, like so. And then we'll be ready to close the wound. The patient will stay overnight. Tonight he'll see therapy. Therapy will see him again tomorrow. He'll be discharged on post-operative day 1. We'll plan to see him back in 2 weeks to look at the wound. He'll have a watertight dressing that he'll keep on until he comes back to clinic. He'll then progress through therapy, and by 3 to 4 months, he'll feel like a new person with a new shoulder, and ideally getting back to all of the activities that he couldn't do before the surgery today. So we're excited to see how he progresses. Hopefully this was informational for you to see the process behind what goes into a shoulder arthroplasty. My goal for you is for you to return to the activities that you want to do and to lead a full and healthy life. And certainly if you have questions about the process, please reach out and I'd be happy to talk about it.